Greetings. Um, so let's continue with our lecture on fluids. So I think so far, just a quick recap, we've talked about fluids. We've talked about how fluids move, whether it be setting up a gradient or balancing things out with osmosis, and when the solutes move, and that's diffusion. We've looked at compartments of our body, and then we've looked at the amount of fluid in those compartments. Next, we have actually spent some time on looking at how water moves through different compartments. And we talked about osmolarity, liters, osmolality, which is mass. We like to use osmolarity, practical. And then we looked at how the fluid moved in and out of cell depending on the number of particles in the area surrounding the cells, which would be the interstitium. Okay. Um, so that's sort of where we look what we looked at, and then we talked about what happens when the osmolarity changes and how the fluid moves from the intravascular space, that's this one here, to interstitial space, and then how there's shifts of fluid between interstitial space and intercellular space. Okay, and we looked at this equation and in terms of fluid going from intravascular space to interstitial space and back. And we talked about edema being a function of inflammation times hydrostatic pressure minus oncotic pressure. So we looked at all of this stuff. Now we're going to continue our conversation on this. So what moves the water or the solvent across the semi-permeable cell membrane? And like I said, it's the difference in solute particles. So as you can see here, there's less solute particles and there's more solute particles immediately outside the cell. Intracellular, interstitium. So the fluid moves from where it's more or less number of particles of solute to where it's less, where there's a higher concentration of solution or higher number of particles of solute, right? Water moves out, cell shrinks. And then we do it the other way around, which is, less particles outside, more particles inside, water moves in, cell swells, right? Cell does not like that. Okay. So we get that point, right? But what? So now I'm going to introduce another interesting concept. What if a solute particle readily diffuses across the cell membrane? So I have the same concept here, and what I've done is in these triangles represent the particles of solute. However, they're special. Why are they special? Well, they move through the cell membrane and they diffuse through the cell membrane and they readily do it. So what happens? Well, if something diffuses very readily through the cell membrane, it's going to go from where it's more to where it's less, right? Remember, we talked about diffusion. Diffusion is what? So here's two compartments and there's, right? So this is compartment 1, compartment 2. You have solute 1 in solution 1, and then you have solute 1 in solution 1, but you have different amounts. So let's say this is, the amount is, again, we have the solute and solvent. So here you have solute amount 2, here you have solute amount 1. You have solution amount 1, solution amount 2, right? So what happens when there's no barrier? Well, the solute, which is S, moves from where it's more to where it's less. So if S2 is more, it's going to move from here to here. If a semi-permeable cell membrane is there and the solute can pass through the cell membrane without any issue, well, guess what? It's like the cell membrane is not there. So the solute is going to move from where it's more to where it's less, because this semi-permeable membrane doesn't really block this particular solute. So it's going to go from where it's more to where it's less till it equalizes on either side. That's diffusion. right? Okay, so we got it so far, right? So if it's diffusing, so here, if you see this diffused, right? So now that it's diffused, this does not contribute to difference in solute particle across cell membrane. So in other words, remember, so when we introduced this over here, this added 4 new particles, right? So this had 0 particles. However, because it readily diffused, here you go. We've got 2 particles here and 2 particles here. So there's actually, it's not contributing to any difference like it is here, right? So that's one of the very interesting concepts, is that if a solute diffuses across the cell membrane, it does not contribute to the difference of solute particles across the cell membrane. Okay, and that makes it ineffective solute. What does that mean? Well, it's not going to contribute to the difference in osmolarity. That is a very important concept. This does not contribute to difference in osmolarity, making it ineffective solute. Okay, so let's look at an example and see if we can make a little bit more sense out of this. Okay, so I have a solution of sodium, glucose, and urea. Okay, it's one solution. It's got glucose in there, it's got sodium in there, glucose in there, urea in there, and it's got, let's say, 1 mole of each. Okay, so it's a 1 liter solution which has all three, right? So what's the total osmolarity? Let's say we just, for the sake of making it easy, it's sodium and not sodium chloride, because if it's sodium chloride, it's going to be 1 plus 1, right? That it's going to add 2, right? And then glucose is going to be 1, urea is going to be 1, right? So it's going to make it 4. But let's say it's just sodium. So let's say the total osmolarity is 3 moles per liter, right? Or 3 osmoles per liter. Well, that makes a lot of sense. Remember, liters, osmolarity. Okay. Now, here's the problem. For our cell membranes and our human body, urea is considered ineffective solute, or in other words, it readily crosses our cell membranes. Okay, so what does that mean? That means that urea is going to do what this solute did here. It's ineffective. So it doesn't contribute to the osmolarity. So in other words, here, even though the total osmolarity of the solution is 3, you cannot add urea to the mix, because it's not, when it goes inside the body, the particles will not make any difference. The particles that will make difference are sodium and glucose, which would amount to 2 moles. So the effective osmolarity is going to just be sodium and glucose, which is 2 moles per liter. This, ladies and gentlemen, is the concept of tonicity. So tonicity is effective osmolarity, or it is a measure of osmolarity that is effective. It does not take into account molecules that are ineffective solutes. Okay, so let's take a look at it. So let's say, can I calculate plasma osmolarity? Yes, we can. It's approximate. Um, and it is 2 times the number of sodium. Okay, so that's the sodium concentration, plus glucose in milligrams per deciliter divided by 18, plus blood urea nitrogen divided by 2.8. Okay, so again, that's calculated. Okay, and that's approximate. Okay, and we'll look more into this in just a bit as well, when we look at this equation in more detail. Okay, but for now, that's how we calculate. Now, if I had to calculate plasma effective plasma osmolarity, what would that be? Well, the 2 times sodium would be there, the glucose will be there, but what about blood urea nitrogen? This is not effective. So this has to be eliminated. So the effective plasma osmolarity, effective plasma osmolarity or tonicity. Plasma tonicity, which is calculated, would be 2 times sodium plus glucose divided by 18. Same thing, I just take the bun out, blood urea nitrogen out. So you guys see the difference between tonicity, osmolarity, and osmolality, okay? When we are looking to measure our osmolarity, you guys with me on this? We want to see what our sodium, glucose, and blood urea nitrogen are doing, okay? That's our osmolarity. When we want to give a solution, when we want to give somebody an intravenous solution, we want to know what the effective osmolarity of that solution is. Why? Because if the tonicity is the same as that of our plasma, it's not, remember, it's not going to change the interstitium, which means it's not going to change the osmolarity of the interstitium, which means it's not going to cause fluid shifts from the intracellular space. This is a very important concept, right? Yes. If I give somebody hypertonic solution, right, it's going to it's going to increase the osmolarity of the extracellular fluid, and then it's going to pull fluid from ICF, right? If I decrease or give somebody hypotonic fluid, it's going to decrease the osmolarity of the ECF, and that's going to push fluid into the ICF or cause cell to expand, right? We've covered this already, but now I know that whatever my solution is, I have to divide it into isotonic, hypertonic, and hypotonic. Okay? And that will tell me what the effective osmolarity is. Because now I know I can have an osmolarity of a solution, but it may have things which are not effective. And what I need is effectively how much this osmolarity is. Okay? You guys with me on this? Okay. Now, let's take a look at another concept. Okay? The effective osmolarity of these three compartments, intravascular, interstitium, and intracellular, when we have hemostasis, or we don't intervene, it is all the same. All three are the same value. Because if they're not, the fluid is going to keep shifting. Okay, so we've covered that concept already, but I want you to keep that concept in mind. Um, I want you to keep that concept in mind. Now, the particles, the actual particles inside and outside the cell are different. So in other words, you may have more sodium outside the cell. So more sodium here and less sodium here. You may have more potassium inside the cell and less potassium outside the cell. Yes, that's there. Not a problem. Okay. However, the sum total of all the particles in and out of these fluid compartments is going to contribute to the effective osmolarity. And the effective osmolarity of these three compartments are the same. Okay. Now, we already looked at how to calculate the osmolarity of the plasma. Remember, 2 times sodium plus glucose divided by, let's take a look up, divided by 18, okay, plus blood urea nitrogen divided by 2.8. Excellent. We're doing really, really well. Now, do we have machines that can measure the osmolarity of the blood? The answer is yes. Okay, we do. So do we have two osmolarities of the blood? The answer is no. What we measure through the machine is the only osmolarity. This is just where we calculate the osmolarity. So the question is, man, why do we calculate the osmolarity if the machine gives us the value? Well, here's the concept. The osmolarity, calculated osmolarity, takes into account the three big components of what contributes to the osmolarity of the blood. So you may have a little bit of stuff which is unaccounted for. Okay? Okay. And so that's one, right? The second concept is, well, if I ingest a lot of alcohol, what does that do? Okay. Or I drink some methanol, what would that do? Well, what it does is it increases the plasma osmolarity that is measured. Okay. But when we are trying to calculate it, because when we calculate, we're not including it in the equation, it does not show up. So suddenly there's a gap. The gap between measured and calculated becomes very, very high. So concept one, there is slight gap that exists, which is normal. However, when there's something in the blood which we have not accounted for other than sodium, glucose, and bun, that gap becomes super, super high. And when it does, I know there's something in the blood other than what I'm expecting that is causing that osmolarity to go high. Okay, now that we understand this, let's take a look at osmolar gap between measured osmolality by the machine minus calculated osmolarity. And the normal gap should be plus minus 10. You may usually have some extra particles that are not accounted for. Remember here? We talked about it. Okay. What if it becomes greater than 10? Now I know there's some toxic ingestion. Okay. So the reason we are studying this is, again, when we talk about sodium and fluid shifts and those kinds of things, this concept will become very, very important. So I want to make sure I'm sharing this with you at this time. So now the question becomes, okay, so I know the compartments, okay? I know that all three have the same tonicity or effective osmolarity, right? I know that, right? That's perfect. And that's why they're all equal. I know that if I start to change the osmolarity of by giving something through the blood vessel, it's going to change the osmolarity of the extracellular fluid and the interstitium, and that's going to cause that cell to expand or contract, swell or shrink. Not good. Okay? Not good. So now the question becomes, what determines the tonicity in different compartments of the blood, right? Because in some compartments you might have more of one particle, and the other compartment you may have more of another particle, right? So let's talk about this and see what determines the tonicity. Okay, so here's some concepts. Remember we talked about when I draw blood from the somebody's blood vessels, right? I put a needle in somebody's blood vessel, I get the blood and I send it to the lab. So let's say I get hemoglobin, I get some red blood cells, I get some hematocrit. Don't worry if you don't understand this, we'll talk about it in hematology. We may get some sodium, we may get some potassium particles, we may get some chloride particles, we may get some bun, we may get some glucose, and so on and so forth, right? So these are all values that are there in the blood. We may get plasma osmolarity. Okay, these are all things that are in the blood. Now, there are things that remain in the blood normally, like hemoglobin, RBC. The RBCs generally, normally don't go into the uh, outside the vascular space. So that's that those are going to be the blood levels. Now, there's some electrolytes and particles that actually do freely get exchanged between the intravascular space and the interstitial space. And that's the electrolytes: sodiums, potassiums, calciums, bund, glucose, magnesium, phosphate, da 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 da, right? So the intravascular levels, the level of sodium in the blood will be the same as level of sodium in the interstitial fluid. Level of potassium is going to be the same. Chloride, bun, glucose is going to be the same. Okay? That's a very important concept. Now, the sodium, potassium, chloride, bun, glucose, all of this will be same for intravascular and interstitial, which would be the ECF, right? EC, extracellular space, right? However, it's going to be different from the intracellular space. So I have one set which is just there in the blood. So the values are only in the blood. I have one set which is I measure, and it's the same for interstitium and intravascular, but it's different for intracellular. And then I have the last one, which is the plasma osmolarity, which is same for all three: IV, interstitium, and intracellular. All three are the same. Okay. So the tonicity or the osmolarity is the same, but the components of the electrolytes are different. So what I did was I created a little chart, and the chart actually has three components. There's the IV, intravascular, interstitial, right? So those two parts would be the extracellular fluid, and then you have the intracellular fluid, right? So I've made a little table, and then on this side I cover the components and whether they're same or different, okay? And then in the red, I usually mark lab values that we need to know, okay? So let's go through it together. And this actually gives you a very good idea. So water, right? So water, what's the total amount of body water? Remember, 0.6 times total body weight for men, and for females 0.5 times total body weight. That's the total amount of water. 66% or two-thirds is there in the intracellular space, 33% is in the extracellular space. Three-fourths of that 33% is going to be in the interstitium, and then one-fourth of it is going to be in the intravascular. And then there's exchange. Exchange of fluid between intravascular and interstitium is based on the equation. Remember, K times H minus O, inflammation minus hydrostatic pressure, K, inflammation, times hydrostatic pressure minus oncotic pressure. That will get the fluid in and out. And then the tonicity will have fluids shift between interstitium and intercellular fluid, right? We've covered this already. Tonicity, it is the same across all three components, all three compartments. This is very important. If the provider or we decide to change anything with tonicity in the intravascular space, it will cascade with fluid shifts in all the compartments till the tonicity is the same. Okay? What is our plasma osmolarity normal? 290 milliosmolar per kgs. And it goes from 280 to 300. Okay? And the big issue is if we change the tonicity, we're going to get the fluids to go in and out of cells. Okay? And that also tells us we need the interstitium and the extracellular fluid tonicity to be stable for the cells to have a stable hydration status. Okay. Now, sodium. Sodium is 135 to 145 milli equivalents per liter. Okay. Milli equivalents. So remember we went through milliosmoles, right? Milli equivalents. So milli equivalents, the concept is you have a hydrogen ion, right? And you have potassium ion, right? So potassium has one charge and hydrogen ion has one charge. It's a proton. And so the way to think about this is milli equivalence is how much amount of potassium will give you that corresponding amount of hydrogen ion, if that makes any sense, right? I will talk more about it in another video, but it's another way where we measure the particles. And essentially 135 to 145 milliequivalents per liter is in the extracellular space. Please know this number, okay? Which means in the interstitium and in the intravascular space. Inside the cell is 10 to 20 milliequivalents per liter. Potassium reverses. It is small amount 3.5 to 5 outside the cell in the intravascular space and in the interstitium, but inside the cell it's 130 to 140. I need for you guys to know potassium outside the cell, which is 3.5 to 5. Okay. Glucose is 90 to 120 milligrams per deciliter. Okay, and it's the same. BUN. So remember urea, 10 to 20 milliequivalents per liter. Need to know it. Because this is an ineffective solute, the concentration is going to be same because it's going to diffuse through the cell membrane without any issue. It's going to diffuse all the way. It's going to be the same in all three compartments. Aha! Remember, ineffective versus effective solute? This is an ineffective solute. Magnesium, 1.4 to 2.1. Calcium, 8.5 to 10.5. Bicarb, know this number, 22 to 26. Phosphate, know this as well, 2.5 to 4.5. Chloride, 95 to 105. And these are all concentrations of the particles in the extracellular fluid, or that's interstitium and intravascular. Okay. Magnesium generally runs 20 to 30 milliequivalents per liter inside the cell. However, the ones that are marked here, let me mark these as well. Let me actually mark it with a red pen so that way you guys learn these. So I do want you guys to know the bicarb, the phosphate, and the chloride levels. Okay. Now, units, uh, like I said, units go with the country and place where you're watching it at. Okay. But it's actually your plasma levels or your blood levels of sodium, potassium, glucose, BUN, magnesium, calcium, bicarb, phosphate, chloride. Okay. You got to know those values cold. No easy way for me to tell you this. That's one. Secondly, you may see some variations in your hospital. Okay, so in other words, you may see potassium 3.5 to 5.1 or 134 to 148. Okay, and so on and so forth. 7 to 21 for BUN. Again, these are some general values I'm giving you. When you are taking an exam, if somebody wants to give you potassium, they're not going to give you, if they want to give you high potassium, they're not going to give you 5.2 because, you know, in some hospitals that may be considered normal. So they'll give you 6.1. Or instead of 3.4 for low potassium, they're going to give you 3. So they're going to give you some lower numbers. So for exam purposes, these are values to kind of focus on. In real life, you're already going to have the normals for your hospital or your clinical practice setting. And so then the concept becomes for your ranges in your hospital or in your healthcare setting, what's normal and if it's higher than normal or lower than normal for your hospital. And when we talk about pathologies or abnormalities, then um, you can apply those concepts with if it's high or low for your hospital. So that's why it doesn't, the pathology and how we manage it doesn't change. The values may change depending on the clinical settings and which one where we're at. And for the exams, they're going to give you values where either they're going to give you the normal and or it's going to be remarkably different from normal or too high or too low. Okay. So some things to think about. Tonicity remains the same, BUN remains the same. But you see sodium and potassium. So, extracellular potassium is lower. Intracellular potassium is higher. Intracellular sodium is lower. In extracellular sodium is much, much higher. Okay, something to remember. Now, third spacing. So let's just talk about third space just real quick. So remember we had the intracellular space, we had the extracellular space. So those are two spaces. There's a third space, which is body cavities. These are cavities with which are lined, and they're lined by these membranes, and the membranes have spaces in them, and these are body cavities. So it's the pleural cavity, peritoneum, and pericardium. One may have increased fluid within those cavities, and this is where it becomes tricky. One may have increased fluid in these cavities or may not, may have increased fluid, it's called edema, in other spaces like the extracellular space. So when we see edema, whether it be in the third space or whether it be in the regular space, which is the ECF, one has to make a determination of whether it's transudate or exudate. So let's just kind of talk about this a little bit. So exudate and transudate. So exudate is inflammatory in nature. Inflammatory means you have inflammation, which causes the proteins to leak out because the capillaries become leaky. And we're going to talk more about this in immunology. And the fluid that leaks out will have more protein in it, and it's going to be not pitting. What does pitting mean? So in other words, if there's somebody's shins are here and they got some fluid here, okay? Some fluid. When you press on the fluid, that fluid is going to go down and it's going to come back slowly up. It's not going to come back immediately. It's going to take some time coming back up, and there's going to be an indentation. This is called pitting. Now, with the exudate kind of edema, there's no pitting. Well, what if there is pitting? Well, if there is pitting, that's a transudate edema or transudate fluid collection. It is non-inflammatory in nature, so you're not going to see any proteins in there. Okay? Now, when you have transudate edema, so remember, whenever you have fluid that's in the extracellular space, right? The interesting part is that the formula remains the same, which is K times H minus O. So K is the measure of inflammation. So that's how I've defined. So with the exudate, it's actually this component that kicks in. With the transudate, it is the hydrostatic pressure and the oncotic pressure, one pushing it out, one pulling it in, that causes this kind of edema. So that's exudate versus transudate. Okay, pitting, non-pitting. That's how you can distinguish between it clinically. If it's in a third space, well, can you press on the peritoneum or the pleura or the pericardium? Not really. So what one has to then do is to tap that fluid or extract that fluid by doing pleurocentesis or pericardiocentesis. Pleurocentesis would be thoracentesis. Okay. So again, we go into these spaces, we get the fluid, and we analyze the fluid. If it's inflammatory, proteinaceous in nature, it's exudate, versus otherwise it's transudate. That helps you figure out what it is. If it's hydrostatic pressure minus oncotic pressure, that's a different set of problems to deal with, versus if it's an infection or if it's cancer, which is causing these proteins to leak out and this inflammation from happening. Okay, so that's a very important clue which helps us tease out what the problems are. Okay, so now let's talk about this. What to focus on? We've got all this information, and the question is what to focus on. So the first thing, when we talked about compartments, we talked about extracellular fluid compartment. The big goal is to assess fluid in the extracellular compartment. That's the ECF. Okay? We're going to look at an assessment. We're going to look in assessment how that's really important. Helps you determine if a person has extracellular fluid volume excess, hypervolemia, or extracellular fluid deficit, or hypovolemia, or they're euvolemic. So hyper, hypo, and euvolemia. Very, very important. Second, what is the concentration of sodium from the plasma? So remember sodium? Yeah, it's so much more in the blood and in the interstitium, and it's very low in the intracellular fluid. I want to know what the concentration is in the extracellular fluid. I want to focus in on that concentration. Third, if concentration is equal to amount of sodium divided by volume of water, which is the solute, right? So I can assess the fluid, I can assess the concentration, right, of sodium, which is what I did with steps 1 and 2. If I have high amounts of water and high amounts of concentration, my sodium overall, total sodium in the extracellular space is going to be high. Okay, and that's what it is. Concentration equals amount, total amount divided by volume. So total sodium in the extracellular space is going to be concentration of sodium times fluid in the extracellular space. Right? Now the plasma sodium is the same as, you got it, ECF sodium. We looked at it a while back. Remember electrolytes? See sodium? It's the same between the intravascular and the interstitium, right? So I draw somebody's blood, I can get their concentration of sodium, and it will give me concentration of sodium in the extracellular space. I can assess the fluid in the extracellular space. So those two would give me how much of sodium is there in their extracellular space, right? Now, this is the part that's really interesting. This extracellular space sodium gives us a good idea of what total body sodium is. Total body sodium is approximately equal to extracellular sodium. Well, how did you get that, sir? So remember you have ICF and you have ECF. Where do you have more sodium? Man, remember 135 to 145, and this is 10 to 20. Whoa, there is so much more ECF here, right? What about the volume? It's got 66% of body water. This has got 33% of body water, right? 2/3 is of water is here, and 1/3 of water is in the ECF. So if it's a 100 kg patient and it's a male, then it's 60 kgs. 2/3, that's 40 liter, is in the intracellular area, right? And then 20 liters is in the extracellular area. Now let's say if the sodium is, I'm just going to go with 15 just to make it easy, right? So that's 600, 15 towards a 60, 600 amount of sodium in there. Okay, now this is 140 and I add 20. Remember, so it's got 20 liters of fluid in there, right? And the concentration is 140, right? So the total amount of water is 2800. Do you see the difference between this? So most of the sodium of the body housed in extracellular space. So I need to know extracellular space, how much fluid it has. I need to know extracellular sodium concentration, which I can get from plasma. That will give me an idea of total sodium in the extracellular space, right? Which gives me an idea, which is the biggest contributor to how much sodium is there in the overall body, okay? And that's the game, because when we start to look at disorders of sodium and water, it's important to know how much fluid is there in the extracellular space. That's one. And how much total body sodium do we have? And we'll talk about it when we talk about pathologies. Okay? So just a quick recap. What did we cover? We talked about the tonicity and how it's the same between spaces, and how some things, when we measure blood in the labs, which is drawn from the blood vessels, we have some things which are just blood specific. We have some that are specific to ECF, and some that are specific to ECF. It's specific to um, ICF, like plasma osmolality and BUN. Okay, we talked about different components and water, electrolytes, and tonicity and their concentration in different spaces and compartments in the body, and which ones do we need to know. We talked about third space and third spacing, and we talked about the exudate versus transudate edema, okay, and how one is pitting and one is non-pitting. And then lastly, we talked about the overall goal with this exercise and learning this. Um, and hopefully this will help you learn the fluid portions uh, and can help with the assessment. When we club this with the assessment, the therapeutics, and the pathology, all of this will hopefully come together for you. Thank you.